Hello, I'm Chris Rogers, a physiatrist in private practice in San Diego. I'd like to thank Jillian and the Interventional Orthobiologics Foundation Committee for the opportunity to speak at this fantastic convention. I think this is my fourth year now that I will be presenting, and although I'll miss seeing all of you, my friends, I think my wife is glad that I'm not traveling and will actually spend Valentine's Day with her this year. I'm going to speak about our FDA IND approved phase 1/2A clinical trial. This will be a preliminary data analysis, and our subject is the evaluation of the safety and exploratory efficacy of an autologous adipose-derived stromal vascular fraction cell therapy product for the treatment of knee osteoarthritis. These are my disclosures. I'm a founder of the San Diego Orthobiologics Medical Group. I'm also medical director for Personalized Stem Cells, which is the sponsor of this study. A stromal vascular fraction can be considered a heterogeneous collection of cells. The subcutaneous adipose tissue is composed of mature adipocytes, the fat cell, and stromal vascular fraction, also referred to as SVF, which contains a heterogeneous population of cells. These include progenitors, such as preadipocytes, pericytes, and endothelial progenitors. Mature cells, such as immune cells, endothelial cells, and smooth muscle cells. And stromal cells, such as ASCs and HSCs. Now, in the published scientific literature, the adipose-derived stem stromal cell has been referred to by a number of different names, such as adipose stem cell, adipose stromal cell, adipose-derived stem cell, and adipose MSC. But the International Federation for Adipose Therapeutics and Science, IFATS, and the International Society for Cellular Therapy established the minimal definition for these plastic-adherent stromal stem cells, which are derived from adipose tissue. And they recommend that we refer to them as the adipose tissue-derived stromal/stem cell, or ASC for short. And the ASC is of great interest to those of us who are interested in orthobiologics, in that these cells exist in an undifferentiated state until an injury occurs, which then induces the secretion of cytokines and initiates the tissue repair process. ASCs are similar to bone marrow MSCs in that they have in vitro multipotency, clonogenic potential, and similar immunophenotype with similar cell surface markers. But unlike the bone marrow, where the MSCs reside in an osteoblastic niche, the ASCs in the adipose tissue reside in a vascularized microenvironment with other cells that you see listed here. Now, you can obtain these cells by a variety of different processing methods, which have increasing levels of stromal cell concentration. On the left, you see unprocessed lipoaspirate, just straight from liposuction procedure. This can then be emulsified, and you can decant off the fluid to obtain a fat graft, which is often done in cosmetic type procedures. You can microfragment, or often it's called microfracture, the adipose tissue and rinse it so that you resize it and rinse it, and this is called MFAT. And then you have this stromal vascular fraction procedure, which we will be speaking to, where you enzyme digest and centrifuge the adipose tissue. And it's not unlike what my brother and I used to do when we were young kids. We would get a box of Lucky Charms, which everybody knows is magically delicious. And it's magically delicious because it has these little sweet marshmallow bits inside of them, mixed in with a bunch of toasted oats, which didn't taste as good. So we were always trying to separate out those marshmallow bits. And so in this way, the unprocessed lipoaspirate is much like the bowl of Lucky Charms cereal, but then as you decant away the milk, and as you further crush it and eliminate some of the adipocytes, you end up with your MFAT. But if you pull out the marshmallow bits, then you get this heterogeneous collection of cells, the HSC, EPC, pericytes, and ASCs, which is the stromal vascular fraction. If you go on to isolate these blue diamonds, the ASC and culture expand them, then you would actually have a true stem cell product. Now, there have been a number of clinical studies published in the literature in the realm of orthobiologics, and this is not an updated list, but it's an ever-increasing list of studies. Many of these are case series, some of them are randomized clinical trials, and they basically fall into the category of MFAT, SVF, and cultured adipose stem cells clinical trials. This is just a brief review of some of those studies. The first case series were 2 patients by Pack in 2011 where he injected stromal vascular fraction plus hyaluronan, PRP, and dexamethasone in patients with grade 3 knee OA, and both those patients were noted to have improvement in their pain and function at 3-month follow-up. Coe in 2013 studied 30 patients who had knee arthritis and performed arthroscopic lavage and then injected stromal vascular fraction and PRP. And at second look arthroscopy 2 years later, 87.5% had showed improved cartilage status, or at least maintained the cartilage status, which is an interesting proof of concept that these cells may facilitate cartilage repair. Hong in 2018 performed a double-blind clinical trial where 16 patients with bilateral knee osteoarthritis received arthroscopy in both knees, and then one knee received stromal vascular fraction, and the other knee hyaluronan. And what they showed is that the knee that obtained the stromal vascular fraction showed improvement in range of motion, WOMAC pain and stiffness scores, and also on their MRI cartilage scores with the MOCARTS and WORMS scores at 1-year follow-up, whereas the group that received the hyaluronan did not show improvement, which makes you wonder why we really needed to do the arthroscopy at all. And so Garza performed this study just published last year in the American Journal of Sports Medicine, a double-blind placebo-controlled randomized clinical trial using a point-of-care device that produces SVF in the clinic, and compared high dose to low dose and then to placebo, and showed at 1-year follow-up significant changes in the both the high dose and the low dose group, but better results in the high dose group. And this is really a fundamental challenge now in orthobiologics, where we continue to have difficulty categorizing what it is we're actually injecting into our patients. So when you're at the bedside, whether it's PRP or BMAC or some form of adipose tissue process, we're not really counting cells like we should. We're not really characterizing the biologic. And this can be achieved if you process the adipose tissue at a GMP facility. A GMP facility is an FDA inspected facility to assure that the biologic product that you create has well-defined identity, strength, quality, and purity, just like any other drug that would be manufactured. And one of the things that attracted me to study stromal vascular fraction produced at a GMP facility is because you can actually characterize your biologic. You can count the viability, the cell count, you can do flow cytometry to know what kinds of cells you have in your biologic, and then maybe as important are the sterility testing for mycoplasma, endotoxin. I assure you that many of the biologics that we inject, whether it's bone marrow or processed adipose tissue, can be contaminated with bacteria, and by testing for that, you can be assured that your product is sterile. These cells can then be frozen for long periods of time and shipped through USB 71 vials, just like your other products that you're used to injecting in patients' knees. Now, I know what you're thinking. You're thinking, well, I can't do this right now. The FDA says that according to their regulatory considerations for human cells, tissues, and cellular and tissue-based products, that making SVF exceeds minimal manipulation, and therefore SVF is a drug. And that's right. And as a result, it needs to undergo the rigorous regulatory pathways for drugs that the FDA has put forth through phase 1, 2, 3 studies before you can obtain your biologic license application approval, which allows you to then treat your patients with this biologic. So that's what we had to do. We had to apply for an investigational new drug application, an IND, which we were able to get, and then we were able to initiate this study. Now, this was a multi-center clinical trial. We had a lot of great help from some outstanding people. Dr. Robert Harmon is the co-founder and CEO of Personalized Stem Cells. He's actually a pioneer in the field of stem cell therapy, having first created a company called VetStem, which treats horses and cats and dogs, and has extensive experience with stromal vascular fraction, along with his colleague, Dr. Mike Dale, who is our COO of Personalized Stem Cells, and then myself and my colleague, Dr. Ambach, who works with me in San Diego. We were fortunate enough to have our colleagues, current IOF president, Dr. Rahul Desai, and former president, Dr. Gerald Malenga, and his colleague, Dr. Jay Bowen, both in New Jersey. We had 3 orthopedic surgeons, Dr. Scheinkop, who has published extensively in this field, and Dr. David and Dr. Hansen, who served as team physicians for San Diego Chargers. And then our friend Dr. Steve Sampson and his colleague Dr. Alfiero in Los Angeles. So we enrolled patients who were 18 to 80 years old, were male or female, had clinical evidence of osteoarthritis and pain for at least 3 months. Radiographic evidence of Kellgren 2 through 4, so we did include patients with severe knee osteoarthritis, which is very different than some of the other published studies that you may have read. These patients failed conservative therapy, had normal laboratory data at screening, and were suitable for lipoaspiration and cell therapy. And then we excluded patients who had contralateral knee osteoarthritis that exceeded a Kellgren-Lawrence grade of 2, or had steroid injection within the last 60 days, were pregnant, cancer, smokers, and some of the other typical exclusion criteria that you might see. Our primary outcome was safety. This is a phase 1 safety trial, and we recorded adverse events that were reported by the patient or by the investigator from patient data, such as physical examination, CBC, CMP, and urinalysis data, patient-reported events, and then any event that was reported by the patient throughout the entire study up to our 52-week follow-up, our post-study follow-up. Secondary outcomes were some preliminary efficacy data. So we used the KOOS, which is the Knee Injury and Osteoarthritis Outcome Score, which is a survey which contains 42 items divided into 5 subscales: pain, symptoms, ADL, sports, and quality of life. This is a validated, reliable, and responsive outcome measure that has been used in knee osteoarthritis studies for many years. It's scored on a 0 to 100 score, where the higher the score, the better the clinical the clinical symptoms and function. And these were reported at screening, baseline, 6 and 12 weeks, and then also post-study at 52 weeks. And this is just our protocol outline showing that patients had a variety of information collected from them at screening, including making sure they satisfied the inclusion-exclusion criteria, that they were candidates for adipose collection, medical history was performed, physical examination, radiographs, and laboratory tests. Then on a separate visit, the adipose was collected, and then following that, a call was given to the patient the next day, where we asked for any reported symptoms or any adverse events. And then later, the patient underwent injection of the biologic product, the stromal vascular fraction, and again, we asked these questions, and again, at follow-up, a self-reported assessment for any adverse events. And then we had a follow-up at approximately 6 weeks, and then a final follow-up at approximately 12 weeks. So the adipose tissue harvest procedure is something that many of you are familiar with. It uses a tumescent anesthesia that anesthetizes the fat prior to lipoaspiration. This is a typical Klein solution. The key point is that you have to wait 15 to 20 minutes for detumescence to obtain a good sample. The samples were obtained from the abdomen or the flank, and we used a Vaclox syringe and a 2.5 millimeter cannula with a target volume of 100 to 150 milliliters of lipoaspirate. And for those of you that maybe haven't seen that before, this is just basically what it looks like. Once you get some experience, you can do it this quickly as well. So you can see the patient's comfortable, not sedated. This is done in the office with monitoring, and you get that nice clean lipoaspirate. The lipoaspirate was then decanted for 15 minutes to drain any excess waste fluid and was placed in a special shipping system that kept the sample cold with a temperature monitor to monitor the product as it was shipped overnight to the GMP facility. And here you can see Dr. Umbach placing the NanoCool pack on the sample and then putting it in the shipping container. Then it arrived at the GMP facility, where you can see here our scientists will then take the lipoaspirate sample and digest it and centrifuge it and process it in a standard manner to produce the stromal vascular fraction product. It's then held for sterility for 2 weeks, sterility testing for 2 weeks, and then once it passes the lot release criteria, it's sent back to the office, where it arrives in a liquid nitrogen charged dewar to maintain temperature, but then it thaws pretty quickly at room temperature in about 20 minutes. It is then drawn up in a standard tuberculin syringe, and under ultrasound guidance, it's injected into the suprapatellar recess, and we ask our investigators to document that they were indeed injecting into the proper location. So our patients, we had 29 that were enrolled in this study. Mean age was 65.6 years, Kellgren-Lawrence grade of 2.9. As I mentioned, we did have some Kellgren 4s in there, so this is moderate. This is on average moderate osteoarthritis. The mean body mass index 27.4, so these were generally overweight patients, and nobody was lost at 12-week follow-up. Now, this is just our preliminary safety evaluation. We graded the adverse events based on mild, moderate, medically significant, or serious. We only identified grade 1 and grade 2 adverse events. There were no serious or medically significant adverse events at either the adipose harvest or post-injection phase. And then our preliminary efficacy with the KOOS outcome score. So the mean baseline KOOS score was 52.5. And then we had a response rate of 82.1% at 6 weeks and 79.3% at 12 weeks. Response rate is defined as that which can be found on the koos.nu website, which is the minimal important change recommended by that group for each subscale. The mean improvement for all responders was 37.3% at 6 weeks and 43.4% at 12 weeks. It'll be interesting to see what happens at 12 months. And then the mean improvement for all patients, for all of the 5 subscales at both the 6-week and 12-week follow-up points, exceeded the recommended minimal important change. And this is just what it looks like graphically. You can see at the bottom there the 5 subscales: pain, symptoms, ADL, sports, and quality of life. The gray represents the baseline score. All the subscales have improved at the 6-week point, greater than the minimal important change, which is denoted by the yellow line. And then there seems to be some further improvement at 12 weeks. And this is what we know from previous studies, is that there seems to be some progression of efficacy as time goes on. So we'll see again what happens at that 12-month follow-up. So in conclusion, PSC01, which is a GMP process SVF product, has a favorable safety profile with no serious adverse events reported. There is clinical evidence of efficacy at 3-month follow-up, and 12-month follow-up data collection is ongoing. A phase 2 randomized placebo-controlled clinical trial is warranted and planned for in 2021. I'd like to acknowledge our personalized stem cell team, as well as the investigational physicians and their support teams who helped make this study possible. And later this year, obviously, we'll be publishing this paper, so that will become available. You can look for that. If you have any questions about where we're at right now with the study, you can email me at this address. Thank you very much for your attention. Have a great conference and happy Valentine's Day.